My name is Sid Papanaba. I'm a radiation oncologist at LCMC. These are two, this is kind of the historical thing about kidney cancer. Radiation therapy does not work on kidney cancer, or as the doctors say, renal cell carcinoma is radioresistant. I put a picture of the Karate Kid, and I put that picture there because he's from the 80s, and I think a lot of this data that came out was also from the 80s. 80s was a good time. I grew up in the 80s, but the trials were kind of like the Karate Kid before he had trained as a freshman. So radiation oncology, what is it anyway? Radiation oncology is there with surgery, chemotherapy, immunotherapy, targeted therapy, has an option for cancer treatments. Most commonly, the patient goes into a room and the tumor is targeted. A large machine, linear accelerator, sends radiation therapy towards the tumor. This is usually done as an outpatient setting, and it's usually done for both tumors and areas at risk. So I'm going to talk about some of the new and emerging treatment options for kidney cancer. I'm going to talk about two things. The first thing is something called SBRT. We'll call it radiosurgery from now on. I'm also going to talk about what's new on the horizon for kidney cancers. Radiosurgery is the way to treat kidney cancer if you're using radiation therapy. What it is, if you look in the NCCN guidelines, they call it as a preferred modality for most instances. This is a highly precise, very specific high dose of radiation therapy. It's designed to overcome some of the biological resistance and treat the tumor very effectively. So the old way radiation therapy was done would be to define a geography and treat everything in the field. On the right-hand side, you see kind of older style radiotherapy. The tumor's there, but there's also normal tissue in the field. And that would be done slowly. Be done slowly because you want the normal tissues to be able to regenerate. Nowadays, using radiosurgery, radiation therapy is done in a very precise way using very limited treatments. The treatment on the left there is done in basically two treatments. It's done very effectively because it has the tumor volume at risk. The normal tissues are out of the field for the most part. So I'm going to talk about using radiosurgery for early kidney cancer. This is a relatively new treatment that's very exciting to us. There have been about 9 or 10 clinical trials, high-quality trials that show this approach to be effective. This is a trial that came out very recently in Lancet Oncology. And I like this trial because they looked at the whole patient. They looked at disease progression. They looked at kidney function. They also looked at kidney function per kidney. And they checked all this data in a very thorough way. If you look at kidney function, as you can expect, in older patients with renal cell carcinoma wasn't the best, but it fared pretty well over the years. Kidney function held up after treatment with radiosurgery. We also saw that when you treated one kidney, because it had tumor, the other kidney compensated, and overall, this helped preserve kidney function. If you look at side effects with radiotherapy, they were very manageable. Patients who had radiation therapy for their kidney cancer got a little tired, but that recovered. A lot of patients kind of felt something was happening in the flank. So did it work? In this clinical trial, it worked pretty well. The average size of a kidney tumor was between 4 to 5 centimeters, and these were significant kidney cancers. In about 70% of cases, these were kidney cancers that were watched and they had grown. So I think this trial wouldn't be meaningful if these were insignificant, very small kidney cancers. These look like these were significant cancers that had increased in size. And this was the results. It looks like control for kidney cancers was very good. Patients were followed on average between 3 and 4 years, and local control was very good. Local control doesn't mean much if the patient's not cured. The majority of the patients had local control and had no spread of the kidney cancer. So this looked like a very good method of treating a localized kidney cancer. I'm really happy that research like this is being done in a very thorough and prospective manner. The mainstay of treatment for this would be surgical resection, the methods that I think Dr. Westerman had talked about, but this may be an option in select patients. It's important, I think, going forward to compare this against different modalities and see what's the best. Even compare this against active surveillance and see the actual impact of using this method on the whole patient. So this is an example. This is a renal papillary carcinoma. It was 4 cm in size. This patient did not have great kidney function. The patient was recommended to have surgery, but this patient did not want to have surgery, and SBRT was used instead. So basically, the doctor looks at the tumor on CT, on MRI, looks at tumor motion, and drops a piece of radiation therapy in a single dose right to that tumor. This tumor was pretty treatable. I think it depends on the location, size, anatomy, and what's nearby. Looking at 6 years later, the solid kidney mass is replaced with a cystic-looking hypodense mass. Kidney function is pretty good. So that's an example. Looking at the NCCN guidelines, these are guidelines that doctors use. They're vetted by national experts. For a small kid, for cancer below 4 cm, ablative techniques are in there. So basically, this would be an option for small kidney cancers. Like I said, surgery is still the mainstay of therapy. Active surveillance is used very often, but this would be one approach. For larger kidney cancers that are early stage, ablative techniques could be used in select patients. The guidelines also talk about radiotherapy. They recommend that it be considered for tumors less than 7 centimeters, and they give specific dose guidelines. Moving on, I'm going to talk about using neoadjuvant radiation therapy for advanced disease. This is a kind of a work in progress, but if we have an advanced kidney cancer, if Dr. Arcot and his team see an advanced kidney cancer, sometimes the kidney cancer is so advanced, the cancer leaves the kidney, goes into the renal vein and into the IVC. This can be dangerous. It can even go into the heart. The patient may need bypass to take it out. It can go and block off the liver. So there's some data done at UT Southwestern about using radiation therapy to help stabilize the clot before surgery. So this is being evaluated very carefully. It may be something that's used in the future. A lot of patients have kidney disease that has left the kidney, that's stage 4 disease. And there's interest in using radiotherapy to treat the primary tumor. This trial is ongoing to use radiation therapy. Trials ongoing for surgery as well. The advantage of this approach is we can start the systemic therapy, continue the systemic therapy, not interrupt the immune therapy. There may be less risk associated with using radiotherapy as opposed to surgery, and it also allows for sparing of the kidney function. This is a trial that we had open where patients get immunotherapy and they're randomized to adding in radiosurgery to the kidney tumor to look at the effect of that. Radiation therapy is used to help with symptoms. This has been used for quite some time, and they can be helpful in specific kidney cancer problems. Brain metastasis. Once in a while, the kidney cancer travels to the brain. This can be pretty scary for the patient, for the family. Patients often end up in the ER, they end up in the hospital, they get a CT, they get an MRI. Outcomes can be poor, and patients can get in trouble with brain metastases. This slide's a little bit busy, bear with me. This is a little tool doctors use when you have a kidney cancer patient. And I think the goal here is not to give up hope. In kidney cancer, it's unusual in that you can control the primary tumor pretty easily, pretty durably. So patients who have brain metastases, who have a good performance status, can live a long time, even with brain metastasis. And if survival is good, it makes sense to go ahead and be aggressive, to be appropriately aggressive and go ahead and try and prolong survival. This data does not include some of the newer methods, so I'm hoping survival will be even better in the future. This is a little spot in the brain that shouldn't be there. It's surrounded by edema. The brain that has edema is not really working very well. We can treat that with radiosurgery in a non-invasive fashion. We put a piece of radiation therapy on that tumor, and a year later, et cetera, the tumor is controlled. Spine metastases. Spine metastases can be very painful. They can be difficult to treat surgically. They can expand the bone. They can break the bone, and they can be very vascular. So this is a piece of tumor in the lumbar spine. It is causing sciatica. Radiosurgery can be used to control the tumor, help with those symptoms. In other cases, when the tumor is advanced, the patient may need surgery. However, radiation therapy can be used to help control the remaining tumor there. So what's new on the horizon? I'm going to talk about two types of PET scans. One PET scan is a PSMA PET scan. It has PSA in the name. It's used for prostate cancer. However, the endothelium of renal cell tumors expresses PSA, and this can be used in renal cell carcinoma as well. It's not ready for prime time yet, but it's data that there's good sensitivity and specificity in this case. If a patient has kidney cancer, there's a marker called CA9 that's expressed in the kidney cancer. So this can be used to create a PET scan to detect kidney cancer as well. Now, we have a lot of good studies, so why would a PET scan be that important? And I think the cool thing about this is you can find it, you can treat it. So there's a new class of drugs called a radioligand, and that has a marker that shakes hands with the tumor, and it also has a piece of radiation therapy, and it brings the two together. And I think this is really the future of radiation therapy because it's very specific. Instead of going through the body, the radiation therapy goes from the outside in. It treats the tumor very effectively. This is data from a drug from prostate cancer, but there's a drug called Pluvicto that's used to treat very specifically to the tumors. And about 2/3 of patients who have this tumor see their PSA drop very dramatically. And if that happens, patients live longer. So it's been a very successful treatment. This can be applied to a lot of other diseases, lymphoma, for lymphoma, neuroendocrine cancer, even kidney cancer. So there's now under development radionuclides for kidney cancer that take a marker for kidney cancer and a piece of radiation therapy, and they bring them together. So I think in the future, so we talked about stereotactic body radiosurgery. It's used for all different types of kidney cancer. It can be used for a very specific cancer problem. We also talked about what's new on the horizon, new types of PET scans, as well as radioligand therapy, where the radiation therapy can be directed very precisely to the tumor.